Hello everyone, this is Chadi Alraies from Arch 2023. I'm really privileged today to be with Dr. Richard Schatz, who gave a phenomenal talk about history and the future of coronary intervention. Dr. Schatz, thanks for being with us.
Sure. Right.
So tell us how this all started, and are we there to treat the patient we see every day?
Yeah, sure. So it's a very colorful history. There's a lot written about it in the history books, but most of the history is wrong. Most of the dates and the people are wrong. So I like to give the talk mostly for the younger doctors so that they appreciate from whence they came, because things were very different. I'm a little older than you, so way back in the 70s and 80s, everybody got a bypass. So if you did an angiogram on a Monday, that patient, no matter what he had, went to bypass on Tuesday.
Oh.
Every patient. So the surgeons were booked, and all we were just pass-throughs. The balloon changed all that, but the balloon had one problem: it was unpredictable. So that's how the stent came to be. I met Dr. Palmaz in 1985. He had been working for over 8 years on the project, but had no intention to bring it to the marketplace. It was a hobby, more for him.
Really?
Yeah. And he would just work until the money ran out, and then he would do another study and another, and then when the money ran out, he'd just do another study. And he had done a lot of work, including carotid stents, PC shunts, iliac stents, aortic bypasses he was already thinking of, and renals he was already thinking about. I met him in 1985, and of course I was interested in the coronaries because I was a cardiologist. And we met just by happenstance, very good fortune for me. And I saw his work and I was absolutely blown away that first of all, he hadn't published it and he hadn't really made any plans. He never even filed a patent because he had no intention of taking it to the market. So when I saw it, having known Gruncic and John Simpson from my old days, I knew that there was some value, and I said, we should really make a business out of this. And he was very reluctant to do it. But his wife, who, Amalia, was a very brilliant businesswoman, she says, no, we should probably make a business. So we tried, and we failed because no one would accept our proposition. Nobody believed the data, even though there was a mountain of data. But we had the good fortune, I had the good fortune of running into an entrepreneur on the golf course one day, a guy who sold hamburgers for a living. His name was Phil Romano. And he was fascinated with the stent, and he decided to give us all the money we wanted. So we started our little company, and then no one was interested in it, so we did it on our own for a while, and then we eventually met J&J, and then that's how it really launched worldwide.
Nice. So this is for the first generation stent, the Palmaz. So how does it start to the story of eluting and drug-eluting stents?
So we always knew that the stent could be used as a portable pharmacy. That's what I used to call it. If you look at our original patent, way back in 1986 or 7, we put a claim in there for drug delivery. I was first thinking about heparin, but I also thought that anti-proliferatives would probably work, but we weren't there yet. So we filed the claims for that to preserve that for future, and once the data started coming out, it showed that the stent was very good for tacking up dissections and keeping the patient out of the operating room. We had a new problem of intimal hyperplasia. So then we just clawed back and looked and said, well, let's try some drugs. So first we tried heparin. We developed a heparin-coated stent, which worked beautifully. We had no stent thrombosis with 1 in a million. So it really worked. But then J&J took it to the next level with the anti-proliferative. So they cut a deal with a company that made sirolimus from Rapa Nui, and that became our very first drug. After exhaustive testing, they did a real good job. And by 2003, they had a working stent that was ready for the market.
Yeah. And the delivery, how was the stent back then compared to now, the delivery?
Big difference. So if you saw my talk, the first thing I always tell everybody is, look, this was the first stent. It was the first and the worst stent for delivery, because we were very limited. We didn't have laser cutting, so we couldn't cut the curves that we needed, even though we wanted them. We didn't know how to do it. We couldn't do it. The laser cutting came out in the 90s, and because our edges were sharp, then going around curves, they would snag. So delivery was a problem. In an easy case, yeah, you'd get it 90% of the time. But a tough case down to circumflex or distal vessels, probably 10 or 20% success rate. So we had to do all sorts of things to make it better. But eventually with the laser cutting, when it came out, people a lot smarter than us, the bigger companies like Abbott or and then Boston, and then Medtronic. They came up with the rounded edges and the preferential cutting, which you could do with a laser. And suddenly we had, again, the worst stent, and we got quickly sidelined by these more clever stents, which we use today.
Yeah.
The AVE stent is basically the Medtronic, and Multilink is Abbott. So that's what it took time and people smarter than us to fix it.
Yeah. So what do you think now about the new technologies of like shockwave and these balloons that are kind of
great? Shockwave's amazing. I saw that for the first time in Europe, maybe when it first came out, and I was very impressed. They were doing it in the peripheral circulation, and I thought it was very clever. I saw no downside to it. And as the data comes out, it's very clear that there's no downside to it. It's very safe. The balloon's a little tough to deliver, but that's not a big deal. You can solve that. And it works pretty much almost every time, even for nodular calcium and for diffuse calcium. So I've been a rotablator fan forever, and I think the IVL is probably a little easier to use. And I think it'll enjoy great success, but it is limited because I always said it's probably 5 or 10% of the population. Rotablator only gets about 5%, but it's only because it's a little hard to use. IVL is pretty easy to use, so I'm guessing it's about 10% population, and it's very clever.
Yeah. Did you notice, compared to the volume of PCI in the cath lab, it's slowly going down?
Yeah.
Is this because the disease we're preventing too much, or it's not discovered?
So, good question. I think it's a combination of both things. I think that the preventive medicine is really works. We have Repatha now, we have all the statins, we have all these other new drugs, and so I think that's a little bit of it, but it's also a reluctance to go to the lab. I think that the medical therapy trials are very interesting. I think it probably just delays you to the lab. My personal preference after seeing the Orbit trial and the ischemia trial is that, I think stenting would still be my first choice for a whole bunch of reasons, but I think the guidelines and the majority of people are very happy just to try medical therapy, and if the patient is okay with that, I think it's fine. But that takes a lot of business.
But that's a good point. That, as you
Absolutely.
said, it's the delaying comes to the lab.
Well, here all you have to look at is look at the data, the hard data, and realize that 25% of the medical trial patients failed within 3 months.
Yes. Yeah.
So they got stents anyway. So if you tell a patient that and say, "Oh, try these two things. We can take medicines or have a stent right now."
Or we go
but
check it out.
but within a few months, you're going to be right back here. Most will say, and first of all, don't have to take very many medicines, right? They would opt to have the stent. So, but
yeah.
It's very good. The data validated that medical therapy works.
Works as well.
Yeah.
Dr. Schatz, thanks so much for your
Sure.
time and for valuable input and for historic input. Watch these videos and others on the Arch YouTube channel. This is Chadi Alraies from St. Louis. Thank you so much.
You're welcome. Nice seeing you.